Hello everyone, today we have an important topic access decisions for venous intervention. As with any intervention, selection of an appropriate access site is critical first step toward success. There are many challenges as multiple access sites may be required. A larger tertiary is usually treated and venous valve can make retrograde catheterization difficult. Careful evaluation of all available imaging and examination of the patient are essential first steps. This presentation reviews various access options for venous intervention with the goal of providing useful overview of the advantage and disadvantage of each approach. Usually, venous access requires ultrasound guidance to make a successful access. And you have to find a good fit and combination between the needle and wire. That means you have to use, for example, 6-inch sheath which has a certain diameter of wire and they require large needle, while radial sheaths require small size of needle and wire. Choosing an access site weighs the benefit and potential risk of each site. Tibial vein. When femoral popliteal DVC extend to the calf veins, access via tibial vein should be considered. The most commonly accessed tibial veins are the posterior tibial veins because they drain a large volume of calf, are relatively straight in course, and are superficial at the medial ankle. The patient can be positioned supine with the foot externally rotated. Vein should be accessed in the most superficial peripheral location possible because puncture in the calf itself traverse the muscle and fascial vein and liable to form hematoma. These veins are easier to work with when thrombosed because patent veins are subject to spasm. So when you have thrombosed tibial veins, it's not contraindicated to gain access inside it. So in general, tibial veins is suitable for acute deep venous thrombosis, which usually require thrombolysis, whatever it's chemical, pharmacomechanical thrombolysis. And this deep venous thrombosis extends into the calf veins, and you can gain access through the thrombosed one, and you can choose posterior one, posterior tibial veins, which is more superficial and straight in course. The limitation of tibial vein access is the size of the sheath that can be comfortably introduced. In a small patient, 6-inch sheath may be the largest size that can be tolerable. This is a picture of the ultrasound imaging of the posterior tibial vein at the ankle. The bird vein arrows can be seen on either side of the posterior tibial artery. The longitudinal grayscale ultrasound image of 21 gold needle and microwire in one of the posterior veins. And here we have a spot image of the calf veinogram with 5 French dilator in a posterior tibial vein. This is the vein accommodant for the posterior tibial vein. This is the wire which is guided by the longitudinal section of ultrasound guidance, and this is the veinogram. Popliteal vein. Popliteal vein access is often very tempting in patients with LU femoral DVC due to the fact that the vein is larger and superficial to the artery when the patient is in prone position. The major consideration for popliteal vein access are the patient's ability to remain prone for the procedures and inability to address tibial vein thrombus. Popliteal vein access through the gastrocnemius muscle should be avoided to decrease risk of bleeding and hematoma formation. Access to the popliteal vein is usually in the popliteal fossa proper. So popliteal vein is good for intervention in case of acute femoral DVC, that means at level proximal to the popliteal vein, and in case of post-phlebitic syndrome and fibrosis and stenosis in the common femoral, extended iliac, common iliac, and in IVC. It has advantage of superficial to the vein, and it can manage large size of the access but it has the disadvantage of bone. Popliteal access has advantage of straightforward ultrasound-guided access, able to treat diseased femoral, common femoral, and iliac segment, can accommodate large bore access and sheaths. Disadvantage: longer device is needed, risk of nerve injury, popliteal nerve, and theoretical risk of causing cuff stasis issue if popliteal vein injured, and risk of hematoma if you are going to transverse a muscle. And it has also disadvantage of position. This is an access from the popliteal, and this is the venogram showing a filling defect of the thrombosed femoral vein. Spot image of the straight venogram with 5 French diameter in the popliteal vein. Spot image of venogram at level of groin showing thrombus in the femoral vein. Small saphenous vein. This approach requires conventional saphenous vein anatomy, with insertion into the popliteal vein rather than continuous as a Giacometti vein. It requires saphenous vein of adequate diameter. The guide wires fall naturally into the popliteal vein with a minimal manipulation. The preferable access in many practice because the vein is superficial and often insert lower into the popliteal vein than can be directly accessed with a needle. Gastrocnemius vein. Access via gastrocnemius vein is similar to the short saphenous vein access, but requires puncture into the posterior compartment. The risk of compartment syndrome should be considered before using this access. So, small saphenous vein is a good access alternative to the popliteal and more superficial, and some say it's easy to be punctured, ultrasound guided, and then at bottom we should have small saphenous vein and into popliteal vein in the form of saphenous junction. This is the short saphenous vein, and this is the wire inside it in transverse section of the ultrasound. So small saphenous vein and tibial access, tibial veins as access has advantage of low risk of the popliteal vein and nerve injury. It can perform all interventions that are performed from the popliteal vein. Disadvantage: slightly more difficult to be accessed by ultrasound being small in size. Watch out for tibial arteries. This is a picture of ultrasound of the short saphenous, saphenous junction, and popliteal vein. This is the popliteal vein. This is the aneurysm, saphenous junction, Giacometti vein, muscular veins. This is the short saphenous veins and its connection into the popliteal vein via saphenous junction. Femoral vein. Diapuncture of femoral vein in the thigh is an alternative to the popliteal access when the thrombosis is at common femoral vein level but extend peripheral, and also in case of post-phlebitic syndrome, fibrosis, and adhesions present at the level of common femoral vein, extended iliac, common iliac, and IVC. Femoral vein is almost directly posterior to superficial femoral artery when the patient is in supine position. Gentle external rotation of hip can change the presentation of vein to permit safe access. Access is deep and compression difficult due to lack of posterior bone support, so the main consideration for the thigh femoral vein access is an exit strategy. So what the advantage of the femoral access? Useful to see and intervene open lower extremity disease that involve the common femoral vein. Case of the chronic occlusion, deep venous thrombosis that involve the common femoral vein. Some issue increased difficulty of access, especially in the large limb, being still lying posterior to the superficial femoral artery and has no bony support, so the exit strategy is a bit difficult. Possible traverse of the small arterial branches, difficult in maintaining homeostatic control at the end of the procedures.
A linear array transducer with a venous exam type is used to perform an ultrasound-guided insertion of a femoral vein catheter via a transverse approach. The patient is in a supine position with the operator at the right side. The transducer is placed transversely just inferior to the inguinal crease, with the orientation marker directed to the patient's right at a 9 o'clock position. The superficial femoral artery is seen as a dark, anechoic, pulsatile circular structure in the mid-portion of the ultrasound image. Deeper and slightly to the right of the image, the femoral vein will appear as a dark, anechoic elliptical shape that is compressible with transducer pressure. Adjust the transducer so it is centered over the femoral vein, medial to the artery. Follow the needle entry by slowly sliding the transducer in the direction of needle advancement. The needle will appear as a small bright dot. When the needle tip appears, the transducer should be advanced a short distance distally to follow the tip of the needle trajectory. The needle is slowly advanced under direct ultrasound visualization until the tip is seen to indent and then puncture the femoral vein. The transducer should be moved slightly proximally and distally to confirm that the needle tip lies in the mid-portion of the femoral vein.
Access by a common femoral vein is familiar to the interventionist, providing a capacious lumen, a good lumen, and easy to be monitored. This reliable approach when thrombus or chronic occlusion is limited to the iliac veins and inferior vena cava with beta of the common femoral vein, a good option for insertion of the filter or removing of the IVC filter. If the thrombus extending into the common femoral vein, more peripheral access like femoral popliteal vein is desired to allow more extensive treatment. In these cases, either common femoral vein access on the opposite side with the use of the long flexible sheath known as up and over access or neck vein access can be used. In which cases, the cases often, if you have filled common femoral vein access, you have option of crossover and option of internal jugular vein as neck vein access. Common femoral vein has a good lumen, a good diameter, and has bony support. You can do pressure against it. Suitable access for the iliac lesions, either it's acute condition or chronic condition, and for the IVC, either for insertion or retrieval of the filter. This may be considered when thrombus extend into the profound femoral vein, given that this is difficult to access with the antegrade approach. If you have thrombosis present in the common femoral vein and profound femoral vein, and you need to make a pharmacomechanical or pharmacological thrombolysis, it will be a bit difficult to gain access through common femoral vein. You need to make access from the opposite side as a crossover or from the long vein. However, valve in the profound femoral vein and femoral vein present a significant challenge for the retrograde catheterization from the neck or from the opposite side. This is a picture of the crossover access from the right common femoral vein to the left common femoral vein, and then access your wire into the profound femoris or femoral vein if you have thrombosis, and the main challenging is valves. Common femoral vein, this is common femoral artery, common femoral vein, and in this transverse section of the ultrasound, common femoral artery, vein, and great saphenous vein. What if the common femoral vein is diseased? Use your pre-procedure imaging to inform your access site choice. If significant common femoral artery vein diseased apparent, little value in access it. Access below the level of the disease to ensure you can access and treat all the necessary segments. If you have a lesion, chronic lesion in the common femoral vein, and it's clearly difficult to gain access directly to treat this diseased common femoral vein, so you need to make more distal access from the femoral or popliteal vein, so you can treat any abnormality and correct any irregularity present in the common femoral vein in case of acute or chronic lesion. This is a picture of common femoral vein occlusion, and you can define it as in comparison to the opposite side as it is more shrunken and more dark in color. Great saphenous vein is useful alternative access to the common femoral vein, can be accessed regardless of whether it's patent or thrombosed, usually large enough to accommodate most devices and the size of different sheath. Pressing are easy to be monitored during thrombolysis, and bleeding doesn't seem to be a serious risk. Also, we have perforators connecting between the great saphenous vein and femoral vein, deep venous system, and this is will be an access to gain the thrombolysis to make clot thrombolysis and lysis of the thrombus present in the deep venous system. The challenge with the access compared to the short saphenous vein is the angulation of the saphenofemoral junction. It will be a bit difficult when you are trying to insert a large size of stents and balloons. And the insertion of the abdominal wall vein into the saphenofemoral junction can make catheterization of the common femoral vein challenging. And you can correct this angulation by using Stiffwire. It may be a bit difficult to pass standard wire followed by standard balloons or stent, but this angulation could be strained using Stiffwire and then passing the balloons and stent over it. But also it's a limiting factor in some cases if you have severe angulation, and it will be difficult to access large size of balloons. However, you can repeat this slide. We have great saphenous veins, alternative to common femoral vein, easy to assess bleeding, easy to make compression, gain access to the deep vein system by perforators, accommodate most devices and different sizes. A bit difficult when you are inserting balloons and stent with the angulation of the great saphenous vein, and will be corrected by Stiffwire. So the advantage of Basilic Access, low risk of common femoral vein injury and thrombosis, can image the common femoral vein for disease involvement. If you have thrombosis in common femoral vein, you can gain access proximal to this point and the great saphenous vein at femoral and popliteal vein. It can perform most interventions that are performed from the common femoral vein. This advantage is slightly more difficult to access by ultrasound. I don't think so. Maybe if it's very small, but if it's sizable, 3 millimeter or more, it will be a bit easy to be accessed. Maybe unable to accommodate a very large bore access. This is a picture of my personal intervention. This was a case of thrombosis, acute thrombosis of the popliteal and femoral, and actually it was acute of chronic, and the access was through the great saphenous vein, and this is post-operative 24-hour thrombolysis, chemical thrombolysis, and you will find the perforator connecting between the great saphenous veins and the deep venous system to make thrombolysis effects. Internal jugular vein access is familiar and routine as common femoral vein. It's familiar for the interventionist and vascular surgeon, and even for the nephrologist in case of catheter insertion, Hooker, permicase, Bordicase, and so on. This access allows for an integrated approach to the brachiocephalic vein and superior vena cava, like in case of IVC filter insertion in pregnant patient, and retrograde approach to the IVC renal and iliofemoral veins, like in case of you have thrombosis in the common femoral and profunda femoris. There are no capacity limitation. It's sizable, large, compressible, multiple access are possible. You can insert multiple sheets in the same session. With the retrograde bilateral iliac vein thrombolysis is necessary. The femoral and the profunda femoris can also be accessed, but valve will be encountered as previously noted. Patients with short thick neck can present challenging for the internal jugular vein access. One possible internal jugular vein should be accessed through as little overlying sternocleidomastoid muscle as possible to minimize discomfort and bleeding risk. Bleeding, particularly during thrombolysis, can be troublesome. It would be sometimes catastrophic. If excessive, it can cause airway compromise. Also, we have a complication like air in the lung, bleeding in the lung. That's called pneumothorax and hemothorax. And accidental injury to the carotid artery or a carotid aneurysm, pseudoaneurysm. So the jugular vein access has advantage of straightforward ultrasound-guided access, low risk of access site communication, can accommodate large bore access, multiple access at the same session, either time to ambulation. Shortcoming and disadvantage passing through heart, it would cause arrhythmia. Potential impractical for lower extremity work, long device is needed. Working in the air, no immediate surface to live wire and catheters. And this is a picture of transverse section of the ultrasound. This is a carotid artery, and this is internal vein, and we have guide wire here. And this is a troublesome complication and catastrophic complication of hematoma after insertion of catheter in internal vein. External jugular vein, useful alternative to internal jugular vein, is external jugular vein. The vein is much smaller than internal jugular but can be accessed in the supraclavicular fossa because it turns medial to drain into the junction of the internal jugular vein and subclavian vein. External jugular vein can be accessed without traversing the muscle, which decreases bleeding risk. This is the external jugular vein, and we have here sternocleidomastoid muscle and internal jugular vein, and this is the wire. Basilic vein access is most often utilized for treatment of axillosubclavian or more central mediastinal vein thrombosis. The advantage of the basilic vein is that in the distal upper arm it is superficial to neurovascular bundle. Also, the vein would be accessed for venous hypertension, upper limb venous hypertension, acute upper limb thrombosis, and of course, old occlusion. The vein usually inserts into the high brachial vein or peripheral axillary vein, permitting effective treatment of thrombosis related to thoracic inlet compression and stenosis. If the vein is not available, brachial vein access can be utilized. This vein is deeper and adjacent to the artery and nerve, increased risk of access complication. This is both image of the left upper arm venogram after access of the basilic vein arrow. This one, and this is the venogram, and this is in the ultrasound the basilic vein, and this is the brachial artery. Subclavian access, a common method for central venous access procedures, Untitled access and chest port. Some issue higher risk of pneumothorax than internal jugular access. Access site thrombosis can result in venous occlusion affecting the entire upper extremity. No natural way to compress and hold pressure, and the potential for catheter malfunction. This is bench of syndrome. Of course, subclavian has more risk of stenosis and subsequent complication with vascular access, risk of pneumothorax formation in comparison to the jugular access, and we have also bench of syndrome. That means that the catheter is unable to make is unable to be well functioning, being it is compressed between the clavicle and first rib, and later on it will be totally transected. This is a picture of bench of syndrome. That means the compression of the catheter between the first rib and the clavicle, and it may have a catastrophic complication of complete transection. And in this case, the sport would give this chemotherapy outside the venous tract, and it would be a bit dangerous and make many complications related to the program. So the subclavian access, it's not the first option in venous access, especially in the catheter, but it would be used in case of jugular vein occlusion or thrombosis. So, general guidelines for the access sizing. Internal jugular vein standard filter retrieval 12 French. Complex filter retrieval require 16 French sheet. Upper extremity central venous thrombectomy would require 8 French. Dialysis work would require 7 French. Common femoral vein, great saphenous vein, iliac venous would require 10 French. Great saphenous vein, short saphenous vein, superficial treatment require 5 to 6 French based on the property device. Popliteal, tibial, and short saphenous, deep venous up to 6 French you can use it, don't worry, it will fit in the tibials and in the short saphenous vein. Anticoagulation and access, a different perspective in holding anticoagulation. In general, no need to hold anticoagulation. In some cases, could urge that anticoagulation is critical. Low pressure, low flow system, it has low risk of bleeding, don't worry. This is a paper, safety of the inferior vena cava filter retrieval in anticoagulated patients, and we have 150 filter retrievals. Three group therapeutically anticoagulated prophylaxis and no anticoagulation, and they didn't find any difference in bleeding rates. Thank you very much for your attention, and see you again in the next presentation.